Welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Feig, High Tech Answers. Thanks for tuning in today. On this program, we address your questions covering the full spectrum of the payment program alphabet, including MU, PQRS, VPM, and more. Today's program, we have a little bit of a different schedule in that we actually have a panel of healthcare providers here today to help discuss how we can all prepare for MIPS. On today's agenda, our experts are going to talk about MACRA, pick your own PACE options. We're going to have our MIPS readiness panel, and then we'll have an open Q&A if we have time. Our experts for SA Ignite, of course, include Tom Lee, the founder and CEO of SA Ignite. Tom's a serial entrepreneur and leading expert in healthcare value-based programs such as MIPS, MACRA, Meaningful Use, and PQRS. You can contact him directly at Tom at SA Ignite. And of course, with him is Beth Houck. She's a VP of Client Services. And Beth, I'm going to turn the keyboard over to you. I'm going to go on mute, and I'll see you back in the queue.
Sounds great. Thanks, Carol. And go ahead, Tom.
All right. Hello, all. Hope everyone's had a great month so far. I wanted to start out by just laying out some information regarding the blog that Andy Slavitt put out back on September 8th regarding different MIPS participation options for 2017. It's gotten a lot of press. There's been a lot of real attention towards this. And what I want to do is give everyone sort of a high-level understanding of what was expressed there. And then we're also going to talk about a little bit what we've heard from the field regarding how folks are really processing this. So really the first thing to note is that, and it's in the title there, is that there's really affirmation that providers really do need to participate in MIPS to some level in order to avoid the 4% penalty on their Part B. And those other ways, those multiple ways to really participate are laid out in these 4 different options. So the first option is reporting some level of data, which will be defined in the final rule, which the blog also verifies will be really by November 1st, kind of reaffirms that the final rule would be out there by that point. And if one meets the some data standard, then there will be no incentive, but one can actually avoid the penalty. The second option is to report for a partial year, report across all MIPS categories, but only report for a partial year period. And that's where there will be some incentive available. And one interesting detail to look for in the final rule is, will there be a date by which a provider or organization needs to declare to CMS which of these options he or she or it will be selecting. So that's something to kind of keep in mind from a timing perspective. So that's the partial year option, some incentive. And then the third option really is full steam ahead on MIPS as was originally planned, which is reporting on a full year of data starting with January 1st, reporting across all categories. And that's where one can get the highest amount of incentive or reimbursement in that for that first MIPS performance year. And then finally, of course, another option that's always been on the table and in the proposed rule and the legislation is participating sufficiently in an advanced alternative payment model, such as a shared savings track 2 or 3 and several others that were listed in the proposed rule, that can net a 5% annual bonus on the Part B, as well as being exempt from MIPS. Okay, so really, generally what we've heard is that this is being very positively received. It's a real indication that CMS is truly listening to the feedback and really taking some measures forward on it. So generally, this is positive for providers as well as many other organizations to have some level of relief, but also for those who really want to full steam ahead, it really all starts on January 1st. So Beth, can we go to the next slide? And what you'll see on the next slide here is really a summary of what we've really seen. I've actually blogged about this on our website. You can check out the details. But really the first point is reaffirmation that the program truly does start on January 1st. There are certainly options that I just showed where you can have shorter performance periods, but you're not going to be able to get the maximum incentive without reporting on a full year. Secondly, again, is reaffirmation final rule will be published by November 1st. The third, which is really strongly, what one can strongly see that it's implied, is that there are really no changes in that blog that are contemplated for 2018 or beyond. So the idea is provide 1 year of some partial relief. The treadmill starts going because we all know that MIPS is a competitive program. There really is a winners and losers type of design to it. The treadmill will start going, and by the time it gets to 2018, it's really going to accelerate much more quickly, and then the financial impacts are a lot larger. The fourth point is having more options on the table also means that organizations and providers have to really evaluate and decide which option is best for them. And that might be necessary to do by a certain deadline. We'll see what's in the final rule, but it's just another real kind of decision process one needs to go through. The fifth point is if you really look at the numbers and you really look at different scenarios, and we've actually done this in a number of, by varying a number of variables and knowing that, for example, the exceptional performance bonus, there's $500 million that still must be distributed. You factor all that in, and what you find is not only are the financial impacts of MIPS over the first 3-4 years of the program still remain very significant, but even in 2017, you not only have the 4% penalty that you must try to avoid by participating at some level, but even the maximum incentive that you can get is still quite meaningful in terms of motivating action. It's a nice way to sort of help fund continual improvement efforts in MIPS for 2017 going forward. And that really relates to the last 2 points, and I'll wrap up and hand back to Beth, is the program remains a competitive program. The MIPS points are going to have a direct relationship to financial consequences. The scores are continuing to be reported publicly. Nothing about the blog post is really changing that. And again, we'll see what happens in the final rule. And really those that are continuing to act early and really get on that track early and start moving on the treadmill are going to continue to have an advantage moving forward. And lastly, we have not seen major slowdown in preparations for MIPS as a result of having these options, particularly among organizations that are really seeking to do very well incentive-wise. And one kind of informal poll, we had the opportunity to talk with about 15 CIOs that are members of CHIME, which tend to be some of the larger organizations. But 12 out of 15 of them all expressed that they will be going for option 3, which basically is the full year reporting as MIPS was originally contemplated. So 80% of those CIOs are all full steam ahead on this. So with Beth, I think I'll kind of wrap there and hand it back to you, and we'll get right into our panel discussion.
Sounds great. Thanks so much, Tom. So as a nice segue from what Tom just went over, which is we know that MIPS is starting January 1st. We convened a panel of folks to really help hear from the field more perspectives on what people are doing to prepare for MIPS. I think we all universally have to live in this stage of uncertainty right now, certainly until the final rule comes out. But we know that organizations like yours listening, as well as the panelists here, are all doing things to prepare for MIPS. So we wanted to bring these people in front of you, ask them some different questions in some specific categories to give some of their insights. I'm really excited because they represent 3 very different organizations, and to some degree, the 3 of them have had fairly different roles in their organizations as it's related to meaningful use and PQRS so far. So thank you for being here, Ed, Dawn, and Darcy. I'm going to start by introducing Ed. So Ed started his career at Franciscan Alliance. We could have left out the year, Ed. That would have been okay. But then he did spend nearly 30 years as the CIO of Community Health Network. He retired, but because of all the fun coming out with the fun that came along with new government programs like Meaningful Use, Ed got back in the game, was serving as a Meaningful Use consultant, and now is at the end of his career back in the same place where he began his career. So he is the IP program manager for MU and ACO systems. Thanks for being here, Ed.
Glad to be here.
Oh, sorry, Dawn, I'm not skipping you. I just happened to put the cursor in the wrong place. There we go. Okay, and then also with us today is Dawn Nee. She is Executive Director of what I know as LEMUR. I don't think that you even use the acronym for Hallmark Health, which is essentially an organization that they are the managed services for the EHR for more than 200 employed and private physicians. She previously was at GE in the software world, serving as Director of Software Development. She also has served as an application analyst at a large health system, Partners Health System in Boston, and even spent some time on the more operations side as a practice manager for a large multi-specialty group. So thanks for being here, Dawn.
Thanks for having me, Beth.
And then last but not least, we have Darcy Trier, who is the quality manager for Swedish Covenant Medical Group. Darcy brings to the table a clinical perspective. She is an advanced practice nurse and has served as a quality manager both over PQRS and meaningful use for Swedish Covenant since nearly when meaningful use started. Swedish has 125 multi-specialty physicians across a bunch of different locations on the north side of Chicago. So thanks for being here as well, Darcy.
Thanks for having me.
Okay, I mentioned it when I was introducing everybody, but before I get started, I want to give everybody a sense of just the diversity here that's on the panel, both in terms of each of their individual experiences, but as well as kind of the organizations that they manage. So Franciscan Health is a large health system. They are in North and Central Indiana. I believe they do also bleed over into Illinois a bit. They are a 14 hospital health system. They have 750 physicians in 260 locations. They also have an MSSP ACO that serves 60,000 Medicare patients, and they are on Epic. Swedish Covenant, as I just mentioned when I was introducing Darcy, is in Chicago in a fairly diverse zip code area. They are a multi-specialty group practice. They have 20 different specialties plus primary care, 180 employed providers. They have served over the past 2 years more than 150,000 unique patients, and they are on eClinicalWorks. And then last but not least, Hallmark is in Boston and in the surrounding areas, and I think you would have guessed that once you hear Dawn start to have her Boston accent. And LEMUR serves as a software as a service EHR practice management corporation. So they have a unique position on this panel in that they serve employed physicians, but they also serve some small private practices as well. So she can really speak from the perspective of having to serve some of those smaller groups. And they are on GE centricity. So we have different size organizations, different setups, as well as 3 different EHRs that we're talking about. So we're going to talk about 5 different topics, and so you're going to stop hearing my voice and you're going to hear a lot more from them. The 5 topics that we're going to try to cover today is, first off, probably the #1 thing that we've heard in our work with different clients and working out in the field with Chime and other organizations is a lot of back and forth and conversations about, hey, how are you organizing to meet the needs of this value-based program, these new value-based programs? So what are you doing differently in your organization structure? So we're going to talk a bit about organization structure. We're going to also talk about how these organizations have been educating the different areas of the organization, so physicians as well as anybody else that might be touching the program, and how do they approach that education. We're also going to talk about the data and what they're doing from an analytics standpoint to prepare themselves, or at least what kind of infrastructure they're putting in place so that they can deal with some of the complexities that the data presents. We'll get a little more reaction on the regulation itself and wind up really just talking about what things they might be doing differently in terms of infrastructure with their EHR, as well as what other advice they might have to offer the group. So I know that's a lot to cover. We're going to try to do that in about 35, 40 minutes or so, and have just a little bit of time for questions from the audience here at the end. So to start us off, I'm gonna start with you, Ed, because I think you have the largest organization. So from an organization structure standpoint, you certainly potentially have the room for the most complexity. So how have you changed your organization structure, or how are you discussing changing how you approach the organization to support the MACRA and MIPS program?
What we're doing is actually just kind of re-looking at our meaningful use program, which is the primary driver of the data, the communications with the physicians, essentially. Since MIPS is an ambulatory program, that's really our focus. And we started out in 2010 with meaningful use, evolved it. We actually have 4 regions. They're now called divisions, but I'll refer to them as regions. In central Indiana, western Indiana, northern Indiana, and south suburban Chicago. When you look at our organization structure from the ambulatory perspective, we do have a vice president, of our Franciscan Physician Network. We also have a medical director of information technology that is currently running our meaningful use program. On a monthly basis. We have meetings. We have our corporate CMIO involved. Each one of the regions has a medical director, physician medical director of quality, who is very instrumental in monitoring and providing, oversight. Also, those medical directors also work with me on our ACO programs. And you mentioned the one MSSP. We also have a total of 5 ACOs, 8 different populations. We have several commercials, about 163,000 lives. So that's been beneficial to our whole organization structure in terms of getting in early and thinking about quality and meaningful use and things of that nature. In addition, each region has one or multiple quality managers that actually work with the office managers. So it's kind of a top-down approach. Most of the activity occurs at the lower level. So that's what we've built over the last 5 years and plan on moving forward with that same type of operation. We are looking at, in fact, we do have approval to move forward with a new position for regulatory programs to focus on not only MIPS but other programs that are coming about, and that will be, I'm not sure if it's going to be their full-time job or part-time job, but it will be a very hectic year. And, so that's really kind of where we're at, is adding the one new position to focus on regulatory programs and keep all of us in line.
So it sounds like you've had a centralize certain things and decentralize other things approach to meaningful use, and you're bringing that forward with MIPS as well.
Yes, and also in our monthly meetings, we actually review reports for meaningful use. We'll do the same thing with MIPS as we move forward, and we share the good and the bad with everybody, in terms of down to the physician level. So that's also an incentive to kind of keep people working hard with certain physicians. So
great, thank you. Dawn, kind of the same question, but also I know, having talked to you many times, that you have kind of a unique setup because you don't have a CMIO. Can you tell me a little bit more about how you handle getting physician input?
Yes. So my organization reports to a board of directors. The purpose of having the SAS model EHR is to have it be physician-driven, and so there's a board of directors in place, of which 6 out of 9 are physicians, combination of private and employed. So they typically will give us direction around implementing a program, timing, any decisions we need to make, changes in the software, and then also they will also give us feedback on the education and the timing of the education that we will provide to the other physicians on the system.
Great. And Darcy, how about on your side? I know that you've for a while had MU and PQRS consolidated under the same person, you. So you haven't had to make that change. Any changes that you've started to consider or been thinking about?
Well, I mean, I've been working on it for many years now, so I feel like I have a really good handle on where it needs to go. But I am working on building committees and getting this back into our quality committee team, so everyone's kind of aware of it early on, so that the changes that as we're identifying them and they need to happen, we can really move that needle earlier than later.
Can you tell us a little bit more about the quality committee, who's involved in it and the role that it plays?
Our quality committee has kind of evolved as our organization has grown and changed. It used to be more of a place to report on things, and then it turned into more of a working team about identifying areas and implementing change to improve our quality. And I think we're kind of in that direction now, so we want to bring it back into that more reporting, where there's the accountability and the follow through and identifying the areas that we still need to kind of nudge a little bit.
Wonderful. So I'm going to start with you and then go backwards, actually. So switching gears just a tiny bit, what do you think are some of the key parts of a successful organization structure? So what are the things that you look for as you're starting to consider what to do or what recommendations to make? Positions must-haves or accountability, authority, those kinds of things.
Yeah, I mean, I think provider buy-in for this whole program is really important. Making sure that they understand some of the whys and the hows of what we need to do to make this happen. You know, getting some excited providers as some leads to help us kind of rally up our troops to get this done, instead of it just appearing as a burden. I want to get them kind of the benefit to the organization overall by staying on top of our quality. So I think that accountability piece and having kind of that structure where that accountability is there. It's not just me sending out their scorecards and then deleting the email. Like we want to have some accountability to make some improvements.
Great. And Dawn, I know you and I have had some conversations about that very thing, considering that you are really the IT group. So tell me what you also see as important for the changes to an organization structure or accountability and authority in order to be successful under MIPS.
Sure. So sorry, I'm having trouble with my mute button there. Yeah, so with meaningful use, it was always seen as an IT initiative, and that worked okay for meaningful use because we basically made changes in the system, trained the providers. They did what we trained them to do on documentation, and then we monitored their reports and helped them get their attestation situated. But with MIPS, it's bigger because there's so many strategic decisions that need to be made about whether you're going to do individual reporting, group reporting, which measures to submit for the providers. And so I feel like operationally there needs to be more investment and buy-in and understanding of this program. With some of the small physician offices, our largest office has 5 providers on the private side. So these are small offices, and so they need education and understanding. And what has happened in the past is they don't care about a program until they get the penalty letter. And then it's my fault or my organization's fault for why they didn't meet it. So with MIPS, we really need to strategically plan and educate people to understand the implications of which measures to submit for quality and knowing what will impact their composite score the most.
Excellent. And Ed, how about on your side? You mentioned adding staff to support MIPS, and you specifically talked about a key role that you're going to add. Other things that you think are important?
Well, the accountability, I think, as Don was talking about, I think this person I think kind of it's a shared accountability. We're going to have a person in charge, but down the line, everybody's got to be held accountable. I think, and to that end, we need to improve the communication and, as Dawn said, education at each level. I fully agree with Dawn's comments. I think stage 1 and 2 have been IT-led, and I think we're now moving into where performance is really going to be the key factor. And so I think that clearly it's got to move out of it. IT will continue to be a participant, but it's got to be led by the ambulatory organization, and clearly that's a direction we're heading. Where I'm heading, hopefully the organization will follow.
So we're going to talk about education in a second, so don't lose those thoughts. But one question I did want to also ask, just to wrap up this section, is we talked about this related to MIPS, or I'm sorry, related to meaningful use, which is when you onboard a physician, you are onboarding their meaningful use past. When you onboard a physician with MIPS, you will also be onboarding their MIPS past. How are you thinking about your organization structure or communication as it relates to onboarding new physicians? Because I think the impact might be even larger, or definitely will be larger under MIPS when you add in a new physician. I'm sorry, I didn't say who to talk. Ed, go ahead and
yeah, I'll go ahead and kick that off, because we've had some internal discussions regarding that. In fact, our initial approach was to look at their past meaningful use as part of their hiring process, and when our finance people, our corporate finance people, actually made the comments is, if they're a good physician, why don't you hire them? I mean, it could be their past organization's fault that they weren't able to attest, through their systems issues or whatever, and that makes total sense. So I think we know we are going to inherit, or it's a factor, but we will not hire a physician because of past meaningful use scores, even though that will drag us down a little bit. We'll just work a little harder to bring them up to speed. So that's kind of a general philosophy of how we're looking at the onboarding process. And one of the other things right now, we are just managing and attesting meaningful use on physicians that we know are eligible providers for either the Medicare or Medicaid program. With the MIPS program, we've had a few people fall through the cracks or gaps in that process. So I think that we're going to be a little bit more stringent about looking at each and every physician a little bit more closely to see if they're eligible for the programs. Of course, under the MIPS program, I think most all physicians will be eligible.
Don, what about you? How is again, your unique organization might have to address this differently?
Right, so this has come into factor mostly with the employed physician group, because they're typically the most active hiring organization on our system versus some of the small private offices. And we struggled with this under meaningful use, because we had providers coming on board, and in some cases it was unclear for who got there, if they came in the middle of a year, who gets their money, when they were paying incentives, how do you share reporting if they need to report for the full year. So we had a lot of struggles with that with meaningful use, and we expect that it will be as challenging under MIPS. And what I've suggested to the leadership within the employed physician group is to consider that within the contracting when hiring a physician, try to research and understand if they're bringing a penalty with them into the organization, because it would be, probably 1 or 2 years before we can eliminate that penalty and even move towards, receiving some incentive dollars or increased payments for doing well. So it's definitely been a struggle, and this ties back in with MIPS is really important from a full operational standpoint and not really just an IT adventure like meaningful use was seen to be, at least in our organization. Oh, and I actually want to add
Go ahead.
Sorry, Beth, can I add one more thing? One other thing we
Sure.
hit last year with meaningful use was the switch of Medicaid physicians. So we hired some Medicaid physicians, and they were doing Medicaid meaningful use in the organization where they had worked previously. We do not do Medicaid meaningful use. We do Medicare meaningful use. So the providers couldn't switch any longer, and so we actually hit the wall where we ended up receiving penalties for some of those providers because we couldn't make the switch for them last year, even though they had met all the Medicare rules and measures.
Got it. Darcy, you mentioned that you have an onboarding committee. Can you tell us a little bit more about that and how that helps, or how you're contributing to that in terms of MIPS and considering how to onboard those new physicians?
We realize that there are some gaps with some onboarding of things that, like, all the departments that need to know that a new provider is here. And I was invited to the kind of launching of this committee, and just because they wanted to make sure that after they're hired that they get in to meet with me. And I brought up a good point of that I need to know a little bit more about them before we bring them in, because they could be coming with this penalty. And we kind of knew that with the meaningful use, but going into MIPS, the penalty that can come along with them is quite larger. And so to have a chance to kind of know that information before their contract is fully negotiated would just be beneficial to our organization. So I think I kind of turned on some lights and some thinking that that's some information that we need to gather before absolute hire happens.
Great. So staying with you, Darcy, I'm going to move over to the topic of education, and we all know that we don't have a solid plan right now. So we don't have the final rule. So as a result, it is how we educate people is obviously going to be in flux. Tell me what kinds of education you have done already and how that was received. As well as what some of your plans are for the future in terms of which people you will educate, won't educate, and what tone you might take with the different groups depending on what their role is in the organization. I know that's a big question.
Sure. Well, for myself, I felt I needed to understand it as much as I possibly could. So I have listened to as many webinars as I could, read as much as I could, and really tried to kind of break it apart into its pieces of the pie of the MIPS score and look at each piece to see what it really involves. And when I did that, I realized that two of those pieces are meaningful use, which we've been doing, PQRS we've been doing. The other two pieces, when you really look at them, are not that difficult to understand. So I kind of feel like I'm not as afraid of it as I originally was when it all came rolling out. You know, that unknown of what it's really going to be when the final rule comes out is still hanging out there. But just to kind of keep my executive level team kind of in the know enough to know that we don't have to panic. I did present a presentation to them, very high level, and really they wanted to know that bottom line impact financially, like what does it mean and what do we need to do for that impact. Our providers have kind of been broadly introduced to it in an overall meeting that it was coming, and this was last year. But once we really get a full understanding, and that's when I'll really roll it out to the provider level, once we really have some solid answers after November.
Makes sense. Dawn, what about you? How has what you did in terms of educating for meaningful use or any other program, I could say, how will that impact your plans for educating all the people that you need to educate?
Right. So the mantra from the board of directors that I report to is just tell the physicians what they need to do. They don't need any fluff. They don't need any background. They just want what they specifically need to add into their already busy day. So that's the approach we're going to take with MIPS as well. I agree with Darcy. I attended every webinar, and once you attend enough webinars, it finally sinks in, and it is much of the same that we've already been doing. So that is helpful to understand. At this point, we've educated leadership, our physician hospital organization leadership, some of the hospital leadership, and then the board of directors over my group leadership. And at this point, until the final rule comes out, you know, staying with the point of just tell the doctors what they need to do, we're really waiting for the final rule to come out to give them the specific things they need to care about. Anything that's happening in the background or that my team is doing for them is not of any interest to them because they're already so busy.
Mm-hmm. Ed, same question back to you. You have a pretty complex and large group of people to educate. Have you done any to date? And then similar to what Don and Darcy said, you know, given that the rule isn't finalized and perhaps you haven't done any, what are your plans?
Well, I think from the very beginning with meaningful use, we built the workflow into Epic using, so they couldn't vary. We reduced the chances for variation, so to speak. Also, we incorporated best demonstrated practices, little pop-ups, things of that nature. So that everybody that goes through the initial training for Epic gets trained in how it needs to work. There's also, as things change throughout the years, we come out with tip sheets, and quite frankly, those tip sheets have been valuable for the providers. They're usually just one page, to the point, you know. And but I have talked with physicians and medical staff also that you know, actually read these and you know, understand these. It also talks about why we need to do things. One of the things that we're working on now, as probably everybody is with the hospital, is moving to the ECQM reporting. That is going to be a major workflow change also, because you have to report directly out of your EMR, you know, into the CMS QualityNet. And so you've got to revise that workflow up front to capture the data, since you can't change it. You can't review the chart and change it after the fact. So the hospitals start in 17, and actually I think the ambulatory is going to start shortly thereafter. So we're starting to think in terms of revising workflows to capture information about quality measures and things of that nature. So again, I think it's going to be focused around system use, coupled with tip sheets kind of explaining why we need to do this and things of that nature. And we also attend various executive meetings, my project manager Lisa Moore and I, and to the point where they're tired of seeing us. So I think, okay, now, but the problem is everything's green every time we show our dashboard. We're pretty compliant. We are very compliant across the board, so it's almost a boring presentation. So we hope it stays that way, but we're going to throttle back our involvement with the various executive committees, maybe every 6 months instead of every quarter.
Interesting, great. Well, you started to touch on it when you were talking about kind of reconfiguring workflows, and that is the data. You know, when you said you were talking about your work configuring the ECQMs and getting accustomed to the ECQM reporting and monitoring that kind of performance. Don, I'd like to actually start with you to talk a bit more about how you currently organize the collection of data for all your value-based programs, and how will that change?
Sure. So currently for both PQRS and meaningful use, we pull the data from our GE electronic medical record using a GE tool called CQR, Clinical Quality Reporting. And due to some limitations on the front end and usability of being able to see sort of the right view across the enterprise and things, we have all the data flow into SAIgnite, which assists with us monitoring the data across our enterprise, selecting the best measures to submit for each physician, and then simplifying the submission to CMS. Going forward, the monitoring becomes more critical, specifically in the quality data, because with over 20 specialties in our organization, it's hard to pick the right 9 measures for a provider to get them the best quality score. So the monitoring that we're using is enabling us to be able to see how they're doing and understand, if they see 2 more diabetic patients a day, then they might be able to make an improvement on their overall score for that particular measure. So that we see as being very valuable going forward into MIPS.
Darcy, what about on your side? You're on eClinicalWorks, so you have a different reporting tool. What are you doing to look at the data differently than, or figure out how to collect and distribute the data differently with the expansion to MIPS?
We're doing something very similar to what Dawn just said. We use our EMR to kind of get that data in a pile, but the EMR itself just doesn't give me the tools to kind of share it like I need to with my staff and my providers in a more readable format to really pinpoint where the work needs to be done on the MU side. Same thing with PQRS. This our first year, we're moving over to using Ignite for our PQRS analysis, and it has just opened my eyes to a very different way of picking my measures. We submit as a G-Pro, which every year I read through all the possible ways to submit, and I think I figured out the best way, and then I question myself every time. And then I come back to the G-Pro. It just seems to make sense for us. But then with the unknown of MIPS, you know, group reporting, individual reporting, I just feel like that is, it's going to be a little more difficult this year to kind of next year to figure out what's the best way for my providers to report.
There is no doubt the complexity increases exponentially in terms of your options.
Right.
Ed, I know you have a different scenario in a way because of your participation in the MSSP ACO. For those providers, you'll be doing G-Pro Web Interface. Tell me a little bit more. You mentioned configuring the ECQMs, but tell me a little bit more about what you're doing differently in terms of collecting data to prepare for MIPS.
Well, I think, you know, first off, we're moving towards stage 3. We meaningful use, that will be part of the MIPS program in the future also. So we plan on going live January 1st, 2018. We're not going to attempt to go in 2017. We need all the time we can get with some of the new objectives. And also, I wanted to point out, you know, the ACO, I think, provides us with kind of a lot of opportunities to kind of slice and dice data. Put in perspective, you know, we've been on the MSSP, where we were one of the 32 pioneers to start off, and then we converted to MSSP. But when you look at the timeline for this, I mean, the program starts January 1st, and then you can report a partial year. I'm assuming they'll follow the same kind of guidelines as the ACOs, that you'll have until February 28th or you know, to submit your final data. You know, and so then when you look at that, following the ACO, we don't get our final report. That's when they crunch all the data. They look at your claims data, and they give us a final report on quality and the actually the cost reduction experience, and that comes out in July and August. So you're talking about programs starting January 1st of 2017, but you won't get your final report till mid-year. Now, that said, CMS is always improving their turnaround time. So that, that's what we are experiencing today. So, you know, the turnaround times will may improve a couple months where you get your final report and know how you've done. So I think one of the things that, while we have all the data, I think we can run different scenarios throughout the year, you know, to see if we want to do a individual, group, or ACO reporting. You know, and so, but we feel we're in fairly good shape, with the exception of the claims. I think the card that's turned down on the table, so to speak, is CMS is holding that is actually the claims data. And the claims data is not just what you're doing, it's wherever these patients have gone, I mean, or providers have worked, that type of thing. So it's to get a handle on that, we've been working with a consultant, Diana Frio, of Coaction Healthcare, and she's kind of kept us in line with tools and capabilities. Yesterday we learned about a program that we were going to research. It's called the QRUR program, which is actually the Quality and Resource Use Report. So I'm not sure how detailed it is yet. I haven't had an opportunity to look at this, but if we look at that data as kind of an indicator of how a physician or how a group organization is doing, we might be able to, in our monitoring, and we could possibly plug that number in, even though it's a year old. It's a trending indicator that we can better manage the the MIPS scores as we move forward. So that's one of the things that we're looking at.
That's great. The QRUR is an excellent resource, and considering that resource category, which I believe is what you're referring to with the keeping the cards down, that could serve as a proxy for that category, recognizing that perhaps organizations don't move dramatically year over year in that category. So that will be a stay tuned portion of this.
Are you incorporating any of that information into SA Ignite?
We are. So we, in general, we are building towards the full MIPS score. So part of the MIPS score is, of course, that resource category, and so we're looking to see what data is available so that we can do the best prediction we can. I
know you've got Medicare Part B charges, and that I think those two pieces with the QRUR and Medicare Part B, I think, can be very valuable proxy numbers, I think, for this first year or so.
We agree, and we do think that there's a MIPS performance report that's going to come out, so we'll really look forward to seeing what's in there. We assume it will be real similar to what's in the QRUR, and hopefully be able to dig in there to use that as a source for some information. So just to give ourselves just a little bit of time at the end for the panel, for the audience to ask all of you some additional questions. I'm going to try to wrap it up by bucketing things in one big place. So I'd like you to just comment in general about reactions on the regulation, and we have all kind of lamented it, like, oh, it's 962 pages, and they said they're making it simpler, and it certainly seems like it's more complex. But tell me whether or not the regulation had any welcomed things in it, whether it served as a impetus for anything in the organization for you, and then based on that as well, if you have any advice for others on what you've done in the early planning that has been helpful, that you've really gotten some positive feedback on. So, Dawn, I'm going to start with you, if you don't mind.
Sure. So for us, I think my first reaction in the program was, wow, maybe our physicians will gain some benefit off all the hard work we've been doing since 2009 for PQRS and 2011 for meaningful use, because I feel like we're in a really good spot. So that was my reaction, and I didn't really want them to push out the rule because I thought getting in early and being ready would be great.
Right.
The second thing I would say is that for our poor private physicians out there in the United States who are 1 or 2 doc offices, there's no way that they can do this without any infrastructure support helping them through, because it's so complicated and so complex. So I think that's where our private physicians are lucky in that they have us available to help them through this, because I think that the private offices, small doc offices, are going to struggle with this a lot. The physician response was really frustration. Just one more thing, I think they feel so overburdened already with all the things they have to document and everything they need to do on a daily basis that this really felt a little overwhelming. So as Darcy said, it's really more of the same. So as long as we can make them understand it's really not a big change in what they're already doing, that may make it seem less overwhelming. And again, we'll boil it down into what they need to do and what they need to know versus the whole thing. And then as far as, sort of advice, I would say that the best thing that I've done, and Darcy mentioned this as well, is attending webinars. I attended webinars, I can't even tell you from how many different organizations, probably at least 8 different organization webinars. And I think hearing it over and over again just helps you to understand the pieces and the strategic thinking and what you need to do. It's a lot of complexity and a lot of strategic thinking, and as Tom mentioned, it's sort of a competitive game, and I think how you strategize and plan for that game, whether you report a provider or not, because maybe their numbers aren't great, you leave them off so that your TIN may not be negatively impacted, which measures you submit, how you submit, individual versus group. I think those are all complex thoughts that need to be strategically, sort of noodled over and discussed among operations, IT, quality, and to sort of make the move forward into MIPS.
Great. Thank you so much. Darcy, any closing thoughts on your side?
Well, I would mirror back a lot of what Dawn just said, but I think for the way my organization is set up and my role, I view my role as kind of the behind the scenes for my providers, that it's my role to set them up to succeed. So I make sure that things are linked and running smoothly, the tip sheets are made, the reports are given, the feedback's given, the workflow gets addressed, and that they don't have to think that hard about what they need to do in their day-to-day documentation and things to help us meet this. And then if I identify that one piece that needs to be fixed, then it's my role to get that feedback to them. So I did have a new provider that joined us, and she has never attested before, and she called me, and what do I need to do? What do I need to do? I've never even heard of this stuff before. And I just relaxed. Most of it's going to get taken care of for you. I'll let you know when I need you to change something in your documentation. So that's kind of how I look at my role, to kind of help our organization succeed.
Makes great sense. And Ed, if you don't mind kind of bringing us home.
Yeah, three points. I think when I looked at the regulation, it's really masterful. When you look back on the program, I think stage 1 was really just incentive to get physicians or providers to use an EMR system. Then they raised the bar. Every year they raised the bar, so it's becoming more intensive. It is overwhelming. I fully agree with that. But then when you look at, we're moving into performance and quality-based years, so they can assure. I mean, essentially where CMS is heading is you're going to take data directly out of the EMR system, to their quality net, and then they can publish it. I mean, so they can take a 18-month turnaround or whatever to more near real time or near quarter real time anyway. So I think it challenges providers and hospitals, healthcare, to look at all aspects of care. So that's my first point. Second point was really, I think I just attended the EPIC user group this week, and the theme was Alice in Wonderland. And as I was sitting through the presentations, it was a perfect theme, because Alice in Wonderland, you had in the rabbit holes. I mean, and that's essentially the stage we're at right now, because we don't know what we're going to, November 1st, we should have a better idea, but we're trying to plan and be proactive, but we don't know what to plan for. So it's overwhelming, and people are looking to us for answers. The third thing is I talked with a number of CIOs at the conference, and if you're struggling now with your EMR system, it's not going to get any easier. So you might want to consider changing. If you aren't, because it's going to just get more. It's going to come faster. It's going to come and be more and more complicated as you move forward. So that was just kind of a key point I would look at from an organization perspective.
Great advice. Well, thank you to all three of you for all of your insights and for sharing your struggles and your thoughts related to this program. Carol, we have 5 minutes, so maybe we have time for a couple questions.
Yeah, and you can hear me, right?
I can.
Yeah, and no surprise that we actually have quite a few questions. Just gotta pull them up for a second. One was related to this issue of CMS neutrality. When several people ask about that from a budget standpoint, can you guys elaborate a little bit more on that?
On the budget neutrality part,
yeah,
and what the new So Tom started to mention that. I'm not sure if Tom's still on or not, but Tom started to mention that when he was talking about the new Andy Slavitt announcement. And basically what people are referring to is in the MIPS program was set up to have winners and losers.
Right.
So to keep the whole program budget neutral. Without, in 2017, having anybody receive penalties, the question has become, well, where will the money to pay the winners come from? So first off, there is some money set aside for the exceptional performance bonus. So that pool of $500 million does not go away. That will stay in place. So that pool of money will still exist. And you will still be able to pull from the people that do not report at all, which will be some percentage that will be receiving the full negative 4% penalty because of simply just not reporting at all. Under PQRS, I think the percentage was in the 30% or so that didn't report. So even if it's 20%, quite a bit lower that doesn't report under MIPS, there will still be a pool of money available there. So that's our thinking so far. We know that the final rule will outline this in more detail.
Okay. And your question, do you have to participate in meaningful use in order to participate in MIPS? We get that question a lot, actually, each month.
Do you have to participate in meaningful use in order to participate in MIPS?
In MIPS, yeah.
Probably meaning if you've participated in meaningful use in the past, like have you ever started? I guess that the general answer is no. So MIPS is a new program, but one portion of it will be the former meaningful use. But if you've never participated in meaningful use before, but you are eligible under the MIPS guidelines of more than $10,000 in Medicare Part B payments, then yes, you would be eligible to participate under MIPS.
All right. And just a resource question: where can small healthcare centers get the detailed information for MIPS and the assistance to properly prepare for the change in January? First of all, reach out to SA Ignite, number one. But number two, I mean, if you Google it, obviously CMS has quite a bit of information on their website about MIPS. One of the panelists obviously recommended like attend webinars like these, right? And lots of organizations are putting on webinars. Those are the two obvious choices. Any other suggestions out there for resources to learn more?
This is Ed. I just Google MIPS, and you have a wealth of information from various vendors. Just about every EMR vendor's got some type of information. So you might go out and visit your EMR vendor's MIPS program website, or but just in general, I mean, it will direct you to the CMS stuff also.
And
also, can I?
Oh yeah, sure. Sorry.
Apologies. So I think many states have different organizations, sort of under the guise of what used to be the Regional Extension Center, but many states have statewide organizations that might help smaller provider organizations to learn and understand this. So really, I think it's a state-by-state thing, but I know Massachusetts has some assistance.
And if you Google any of this, I think it does help to put MACRA in there too, because MIPS is an acronym for something completely different. So it's some sort of engineering thing or something. But anyway, I forget what it is. But I would put MACRA in there too. You get a little better.
MACRA MIPS would be a safe yes.
Yeah. One more question, and then we're going to wrap up real quick. Ed mentioned that we will not have to worry about the 2015 edition until 2018. Will the other panelists be using 2014 or the 2015 edition for CERT, for Certified EHR Technology?
This is Dawn. So we're going to stay on the 2014 edition probably until right before 2018, and then we'll switch.
All right. We have a lot of questions actually pouring in right now, and our apologies that we won't have time to take these. But you can reach out to Beth at SA Ignite and Tom at SA Ignite, and I'm sure they can get you to our panelists. And we appreciate all of our attendees today. We'll be back again next month for another ABCs of MIPS, and we, of course, will get a copy of the slide deck and the recording out to all of you. Again, thanks for taking your time today. Beth, the panelists, what a great job. We appreciate it.
Thank you so much.
Bye, everyone.
Bye.